Okay, this is part two of the shoulder complex lecture. We ended with the different motions that are allowed at the glenohumeral joints, and now I want to give you a chance to see them on an actual cadaver.
Let's look at the movements that can occur at the shoulder joint. Movement forward and upward is called flexion. Movement downward and backward is called extension. Movement away from the side of the body is abduction. The opposite movement is adduction. Rotation which moves the front of the arm towards the body is internal rotation. Rotation the other way is external.
Okay, and really what I wanted you to see with this is what we did with the other videos. If you look at the motions and notice how the muscles either shorten or lengthen with the motion, gives you a really good idea of which muscles are involved in the movements and which are just along for the ride. Next, let's talk about the scapulohumeral rhythm. This describes the way the sternoclavicular, the acromioclavicular, the scapulothoracic, and the glenohumeral joint move together to achieve overhead movement. We're going to talk about this in the context of shoulder abduction, but we could also say it happens the same way with shoulder flexion. So as you move your arm from the resting position at the side through full overhead movement, all these joints need to work together to allow that to happen. And as we look at this movement, at this particular movement, we can split it up into three phases. The first phase is the initial movement as you start to move away from your body. So what's going on here is the glenohumeral joint abducts the humerus about 30 degrees. There's 30 degrees of abduction. The scapulothoracic joint has minimal movement. In fact, it's just preparing for what's going to happen later in the movement. So it's referred to as just setting in this phase. And the clavicle can go up to 5 degrees of elevation. Now, if you recall from the video in the other lecture, the joint mostly responsible for any movement of the clavicle is the sternoclavicular joint. The acromioclavicular joint is also involved, but it only moves enough to let the sternoclavicular joint do what it has to do. So even though we're talking about both of these joints with the clavicle, it's really the sternoclavicular joint that contributes the most. So phase one is what we just talked about. Phase two, the glenohumeral joint abducts the humerus an additional 40 degrees. The scapula now has contributed some significant movement. What we see here is 20 degrees of upward rotation. And the clavicle has also elevated an additional 15 degrees. So to anyone just looking at a person moving through abduction, phase two is 90 is what we would call 90 degrees of abduction. It looks as if somebody is holding their arm out at 90 degrees. However, if you look at this, you'll notice that the glenohumeral joint has only contributed 70 degrees of this total movement. And that's important to note later as we finish the third phase. The scapula also plays a role in overhead movements, and to elevate your arm 90 degrees of abduction, really what's happened is the glenohumeral joint has contributed 70 degrees and the scapula 20 degrees. And of course, the clavicle has to be able to elevate in order for this to occur. And then finally we have phase three. So phase three is the end of the movement. Now the arm is fully abducted overhead. So what's happened here? The glenohumeral joint has gone through an additional 50 degrees of abduction, and along with this there's been some external rotation to clear the greater tubercle. The scapula has rotated 40 degrees into upward rotation, and the clavicle has elevated an additional 15 degrees and has now also gone through anywhere from 30 to 50 degrees of posterior rotation. All right, so if we count all this up, the glenohumeral joint has contributed 120 degrees of full overhead movement. The reason that we can reach a full 180 all the way straight overhead is because the scapula also contributes a significant range of motion, 60 degrees. So the 120 plus the 60 degrees gives us the full 180. And of course, none of that is possible if the clavicle, specifically at the sternoclavicular joint, doesn't allow the movement that you see here. So as we look at this, we get 60 degrees that of overhead movement is contributed by the scapula and 120 degrees by the glenohumeral joint. We can reduce this and get a ratio of 1 to 2. So for every 1 degree that the scapula moves, the glenohumeral joint moves 2 degrees, or vice versa. For every 2 degrees the glenohumeral joint moves, the scapula has to move 1 degree. This is the scapulohumeral rhythm, as it's commonly referred to, the 1 to 2 or the 2 to 1 ratio. There's some research that suggests that there are other ratios that are more accurate, but this is the most commonly cited, and so we'll continue to use this. But the point is that for you to be able to reach overhead, the shoulder joint, the scapula, and the clavicle all have to contribute to get you there. If any one of these joints isn't, if the mechanics are altered in any way, then you'll start to see problems with overhead movement. And so the scapula, then, to answer the last question, has to move this way, because otherwise we'd be unable to fully reach overhead in a way that's very necessary. Now, with this movement, of course, muscles are responsible for moving this. And there are several muscles that are responsible for the different movements that occur at the scapula and at the shoulder. And as it turns out, each of those muscles are pulling in different directions, and so we get force couples that act on the scapula. And we'll start with that one. As you upwardly rotate the scapula, there are muscles that control those movements. The upper trapezius pulls the scapula into elevation and into upward rotation. But there has to be a balance so that there isn't too much elevation, and the lower trapezius provides the opposing vector into a downward pull so that the elevation isn't excessive, and the lower trapezius also contributes to upward rotation. So the lower trapezius balances the elevation of the upper trapezius, and both contribute to upward rotation. Part of moving your arm overhead means that your scapula has to abduct, or move away from the midline. The serratus anterior muscle is the one that is responsible for this. In addition, it also contributes some to upward rotation. So the upward rotation part we've got covered, but if there's too much abduction of the scapula, that could alter some of the joint mechanics. So we need an opposing force for that abduction, and that comes from the middle fibers of the trapezius, the middle trapezius muscle. This vector is in a medial direction and helps to counter the abduction from the serratus anterior. So even though these muscles are working in different directions, the end result is one motion of the scapula, and that is upward rotation. We also have a force couple at the shoulder. Now, if you can imagine somebody standing with their arm at their side, as this person starts abduction, the deltoid muscle is what is responsible for this. If the deltoid muscle acted alone, then what would happen is there would be a vertical shear of the humeral head against the acromion. In other words, the deltoid would pull the head of the humerus up against the acromion process of the scapula. Now, as we'll see in just a few slides, there are some important structures that are passing underneath that acromion process. And if the humeral head continuously butts up against the acromion process, then these structures are going to get repeated forces that they aren't normally, that they don't normally have to handle, and so that leads to some problems. So we can't have the deltoid acting alone. We need to have an opposing force to keep that humeral head from butting up against the acromion. So this is the job of the rotator cuff muscles, specifically the subscapularis, the infraspinatus, and the teres minor muscles. These muscles pull the humeral head down and keep it from butting up against the acromion. In addition to this, they also provide the external rotation that is necessary to clear the greater tubercle as you move through full overhead elevation. And specifically, the muscles that provide external rotation are the infraspinatus and the teres minor. So why do we have to have these forecouples? What's the significance of them? So the scapula is actually, they act as the pelvis for the upper extremity. And we can't have distal mobility without proximal stability. And it's the reason that we stabilize when we do MMT. If we stabilize the proximal segment, it makes the motion easier for the patient. So same with the upper extremity. If we want to be able to move the arm, we need to provide some proximal stability. Obviously, the scapula are significantly more mobile than the pelvis, but we need a way to keep that area stable so that muscles that move the humerus can do so. And that's what these force couples are intended to do. They allow the necessary movement for function of the upper extremity, but balance each other so that there is stability as you move those distal segments. These are some of the muscles that we just covered. The upper trapezius here, and you can see the direction of the vector because of the angle is in this direction. It is countered by the lower trapezius fibers over here. The serratus muscle shown down here pulls this direction, and it's countered by the middle fibers of the middle trapezius going in this direction. Here we have the muscles of the rotator cuff, and you start to get an idea of some of these structures that are crossing underneath the acromion with this view here. And so if the humeral head were to continually butt up against the acromion, there are going to be several structures that aren't going to be happy. So the subscapularis here, the infraspinatus, and the teres minor all work to keep the humeral head seated on the glenoid fossa. And this is just an overhead view of the rotator cuff muscles. The coracoacromial arch is the roof of the glenohumeral joint right through here. And it's through this little bridge that certain structures pass underneath. There's approximately 1 centimeter of distance that exists between the undersurface of the arch here and the humeral head. So there's not very much space there. And again, there are some structures that are crossing underneath here that need to be protected. So there's a delicate balance between the position of the humeral head and the structures underneath the arch. So what makes up this arch? We have the acromion process here, the coracoacromial ligament here, and it attaches over here on the coracoid process of the scapula. This is the anterior surface of the scap, and here's the posterior. What runs underneath this arch? There are 4 structures in total. The subacromial bursa sits underneath the acromion process. The subdeltoid bursa sits underneath the deltoid muscle. That's not shown here. This is probably the one that will affect you guys the most as you start to practice, is the supraspinatus tendon. It runs right underneath that ligament and the acromion as it makes its way to the greater tubercle of the humerus. And the long head of the biceps also runs through here. You can see that here as it comes up on top of the humeral head. And it also runs underneath this arch. So this is a very compact space. If the joint mechanics are altered, these structures can come under pressure that they are not intended to take. This can lead to inflammation of not only the bursa but also of the tendons, and with enough pressure over enough time, there can be some negative changes to these tendons. There could be fraying of the tendon, calcification of the tendon. Often with enough pressure over enough time, it can get bad enough that a decompression surgery is necessary. So here you see the coracoacromial ligament at the coracoid process, and the arch in this whole space here is the coracoacromial arch.
The tendon of supraspinatus runs through a tight spot between the acromion and the head of the humerus. There's a synovial-lined pocket, a bursa, here between it and the acromion. The tendon of supraspinatus runs.
Alright, so just wanted you to get an idea of how small that space is here. You can see the tendon running through there, and of course it doesn't show the bursa that are also included in this space. Alright, so let's move on to a different region of the arm. This is the axilla. And the axilla is the space inferior to the glenohumeral joint. It's your armpit. It's the junction of the arm with the thorax. And it's through this space where the arteries that supply the upper extremity with blood and the nerves that supply the muscles with innervation travel through. And this is the main reason why in 1409 you learned that patients should not rest on their crutches. These structures run right through here, and with enough compression you start to see the signs that come along with loss of blood supply or compression to nerve tissue. The boundaries of this area are the pectoralis major in the front, the latissimus dorsi on the posterior side, the serratus anterior and the thoracic wall is the medial border, and the shaft of the humerus makes up the lateral border. And let's see a video of that.
Two have much in common. Pectoralis major on the front and latissimus dorsi on the back. These two are alike in that they both pass directly from the trunk to the humerus, bypassing the scapula. Between them, they define the posterior and anterior walls of the axilla. Two have much in common.
Alright, so there you get a look at the axilla, and it's probably this view where it looks the most familiar because you can actually see the armpit. But right through there is where the vessels and the nerves travel from the cervical region down into the upper extremity. The blood supply to the upper extremity is actually quite easy because it's one main vessel, just gets different names as we travel down the arm. They actually start, this vessel starts at the brachiocephalic trunk of the heart, so somewhere over here, and as it travels away from the heart, we start to give it different names. So up here is the subclavian artery. As it moves a little further down towards the axilla, it's the axillary artery. And then into the arm, the upper arm, it's called the brachial artery. So this is one of the main sites for blood pressure. And as we travel further from the upper arm into the elbow region, we get a fork in the road. The radial artery on the thumb side, the ulnar artery on the small finger side, and they travel this way until they reach the hand, and there's an arch that comes on both sides of the hand and lets the blood supply travel through the different parts of the hand. These are the muscles grouped by how they act on the scapula. So these are the main motions of the scapula: elevation, depression, protraction, retraction. But remember that we can split up protraction into two components: upward rotation and abduction, and retraction into downward rotation and a deduction. So these muscles, you'll find, have several different pulls on the scapula. Some that elevate also upwardly rotate, and some that elevate can also downwardly rotate, just depends on the origins and insertions. So as you start to organize these muscles, you'll start to recognize that there are going to be several actions that are allowed by these muscles. Something for you to have as a reference. I know you've got your atlas, but this is just another view of some of these muscles. Really, the best ones are when you can isolate the muscles and it looks a little bit like the schematics that are given in your atlas. For this next series of images, what I'd like for you to do is simply take a look at where the attachment points are, the origin and the insertion. See if you can figure out just by the image which is going to be the origin and which is the insertion, and then from those two attachment points, if the muscle shortens, what is the resultant action? So this is the pectoralis minor. Here you see the rhomboid minor and major on the left and the levator scapulae on the right. Your subclavius, the anterior fibers of the deltoid, the coracobrachialis, the pectoralis major, the posterior deltoid, the teres major, both views, one is a posterior and one is an anterior view. The upper trapezius fibers you see here, the middle fibers here, and the lower fibers here. And your latissimus dorsi covers up the remaining part of the back. The middle fibers of the deltoid, the supraspinatus, the subscapularis, the infraspinatus, the teres minor. This is where we'll end this lecture. I'm going to post a series of videos that would kind of help tie in the first lecture with this one on a cadaver.